all with us. We know that you all are busy and have, full work lives and maybe home lives at this point now, especially being affected by the pandemic. So we do appreciate your time taken and taking a look at this webinar. We will have plenty of time for questions and commentary later, but let's go ahead and get started. Next slide, please. There we go. So here's how the general layout of our presentation will work. We'll have a brief time of announcements. I will be welcoming all of our speakers here, and then we will again have some time for questions and comments toward the end. Next slide. All right. Just an FYI, we will be muting all of the lines other than speakers whenever this presentation starts, so probably by right now, just to avoid background noise and for recording purposes. If you do have any questions during the presentation, we would request that you send your questions through the chat box. As mentioned, we will have scheduled breaks for questions. They will be read by our moderator and then answered by the presenters. If we do happen to have a lot of questions and there is any of them that cannot be answered during this call, we will follow up with our team and get those answered for you afterwards. Next slide, please. We have designated this with 1 AMA credit of CME Category 1. Next slide. And this is how you will obtain the CME credit. We will be sending you a link after the presentation so that if this applies to you, that you can get this and fulfill your CME obligations for licensing. Next slide. The presenters have let us know that they have no financial relationships to disclose and they will not be discussing any off-label products. And we would like to thank our program partners, the Government Resource Center at the Ohio College of Medicine, the Ohio Department of Health, the Ohio chapter of American Academy of Pediatrics, and the March of Dimes. They have supported us greatly in this project and in this presentation, and we are grateful for them and to everyone that is here today on this call. All right, a very brief word about me. I want to make sure we have plenty of time for our speakers. I will say that I am an internal medicine and pediatrics hospitalist at Nationwide Children's Hospital and Ohio State University in Columbus, Ohio. I am the medical director for the Healthy Mom, Healthy Family program, otherwise known as Implicit. You'll be hearing a little bit more about that program later. I have been involved in infant mortality, child mortality, and maternal health efforts for the past 8 years, and we look forward to giving you all this information today. Let's turn to Dr. Harris. Dr. Harris, Emily Harris, is a psychiatrist in the Division of Psychiatry and a pediatrician in the Division of General and Community Pediatrics at Cincinnati Children's Hospital in Cincinnati, of course. She is triple board certified in pediatrics, psychiatry, and child and adolescent psychiatry. Her clinical interests include general pediatrics, early identification and treatment of mental health disorders and factors, improving awareness and prevention of mental health disorders in youth, childhood depression, anxiety disorders, and ADHD. Dr. Harris has engaged with the Ohio AAP and quality improvement projects as an advisor for several years. With that, I am happy to turn this over to Dr. Emily Harris. Go ahead, Emily.
Mm-hmm. Thank you so much, Dr. Macklin, and thank you, Haley and Dr. Macklin, for inviting me to come share this project with you. This is absolutely near and dear to my heart, but I also learned a lot doing this project about maternal depression and what our role could be as pediatricians. Go forward. All right, so I'm going to spend a few minutes clarifying the pediatrician role in addressing maternal mental health, as well as examine how maternal depression can affect child health and child development. And then my colleague is going to propose some strategies to identify maternal depression during the high-risk period following childbirth. So I think when I first was invited to this project, this was my reaction of, I can't treat the mom. I can't take care of the mom. She's not my patient. And when I'm doing primary care, our focus is on the child. And so I challenge myself to look at it a little bit differently. And we often do this already, is kind of making sure that the parent is healthy as well. So they're taking care of the child. So this is a great opportunity when they're at high risk. Go ahead with the next slide. Oh, these are some of the funny books that I came across while I was working through. So basically, ma- major depressive disorder, especially postpartum depression, typically peaks at about 6 weeks after delivery of the child. And Dr. Venkatesh is going to talk more specifically about the mom, but I just wanted to offer briefly that, while major depressive disorder, the first spike peaks at about 6 weeks, you could even have chronic depression, and it's mentioned as dysthymia, but really a chronic recurring depression. That happens around 2 or 3 months. And then again, there's another major depressive spike at 6 months. And usually postpartum depression definition wise is within like the first 12 months, most of the cases are going to present. So moms actually get a postpartum visit with their OBGYNs, but it's just one at 6 weeks. And a third of the moms don't even make it to that appointment because moms usually stop taking care of themselves in the first like year and a half to 2 years after a baby's born. And advance. And why is that? Because they're always in our office. They're always at the pediatrician's office. EPSDT screening at the newborn visit, 1, 2, 4, 6, 9, all these visits that they have. And that's not even counting the other acute visits that we do with them. But basically, the research has looked at over that first year, when they have repeated screening, um, while the depression's supposed to peak at 6 weeks when you have that 1 to 2 month visit, but often it's negative, and then it might peak later at 6 months or at 12 months. So after they looked at repeated screening at these particular time frames, they were able to pick up 13% more moms that were at high risk for depression. So pediatricians identified a lot more moms that would not have been confronted with any medical care at all um, other than coming to the pediatrician with their child. Next. So thinking about what depression does and how it acts, it's the two main themes of it are anhedonia, where you're not finding pleasure in things, like nothing is, it's hard to be happy and enjoy things. And such a critical part of child development is that birth, and that making that connection and forming that attachment is critical. And also the other piece is this irritability or kind of agitation that can happen too. And it really leads to different ways that a mom is going to be a mother, and it's a difference from baseline. So it's a change in how she would parent had she not had depression. Usually when mom is acting like in an apathetic way or having trouble concentrating, like not seeming to care, they often have poor limit setting, like the following through with consequences is difficult, recalling what you had and things like that, and just kind of like knowing what parenting strategies to approach are very different. So the child and the baby actually doesn't really learn how to regulate their emotions and behaviors, because they may cry at one point, mom picks them up, and then maybe the baby's crying for like hours and there's no interaction. So that connection of mom keeping you safe is not being made. And feeling irritable, anhedonic, and not motivated to do anything, you can often model what you don't want to be as a parent and have, harsh parenting or aggressive or inappropriate, um, more hostile interactions with even the baby. And for those who have had babies, myself, I have been at the point where I'm like, oh, that's why they showed us the video of don't shake the baby, because I've gotten that tired, that upset, and that distressed while caring for an infant. And especially for moms that are doing this by themselves, it's a very incredibly strenuous, but there's also a lot of strengths and lots of resilience as well. But I wanted to highlight Brooke Shields. I think she was probably in my generation one of the first celebrities to offer her history and walking through depression. And she had pretty severe depression with psychosis after her dad died when she was pregnant with her first baby, and then walked through treatment, and with her second pregnancy had a completely different experience. And if anybody has had a chance to read the book or listen to the podcast, I highly recommend it. Gives a good view of someone's perspective in depression after babies. Next. So when you have a depressed mom, they have a harder time responding to the infant cues, and they often are going to have more negative interactions or report more negative features of the baby. And children have a higher likelihood of behavior problems as well, like ADHD, and they have more depressive symptoms, and they're at risk also to continue the cycle of harsh parenting. So thinking about this in terms of like what this does at that particular moment in development with that 0 to 2, which is the ages that we're framing, young children and young infants even are vulnerable when safety and harm. You think about the reason why babies cry, it's to sometimes just compete for resources. Sometimes it's just to get their needs met, or be taken care of. And if the ability to cope is directly related to the caregiver's response, if they're having a depressive, withdrawn, irritated response, that's definitely going to affect the function of their parenting and their parenting style. And go ahead with the next click. All right. So thinking about those like psychological developmental stages, thinking about Erickson, where the baby's born, and it's like trust and mistrust. Like, am I going to trust that when I cry, you're going to help me? Who is there to, take care of my needs because they're helpless? And thinking about like emotional and babies who have responses to trauma. And this is particularly violent trauma, but I'm going to bring up why I'm bringing this up now soon. So that there's emotional distress. They can have sleep disturbances, excessive crying with separations, and they change their ability to self-soothe. Over time, they can even regress, be less autonomous walking around. And I wanted to bring up that a lot of kids, make it to preschool, and then they're playing out the aggressive, kind of irritated, harsh role, and that can lead to a lot of peer problems and socialization issues, which is often how things are picked up too. Okay. All right. So thinking about it, the risk in pregnancy, during pregnancy, having abortion or having depression is very important. Being able to have it treated, and for the infants when they're born, they may act in like an angry or protective style of coping, maybe passive, have trouble regulating their behaviors, and it actually affects like brain development. We'll get into that in just a little bit. The older the kid is, actually these effects of maternal depression throughout childhood, even at that 0 to 2 year stage, can affect children up to even their teenage years in terms of their risk for depression. So youth who had a depressed mom, even at 0 to 2 months, were more likely to have a depressive order at 16 than other children whose parents didn't, or whose mom didn't meet that criteria. Go ahead. And this is something near and dear to my heart. This is why I did the triple board, this concept of stress. And thinking about it, I'm going to skim through it very quickly, but it's actually one of my favorite things to talk about in terms of, what's happening when you're under stress. And the lower brain develops first, and it's like the survival center. So the breathing, the, body movements, everything like that. And these are the different elements of the brain. Basically, that sympathetic nervous system is the gas to turn on the fight or flight pathway. We all know that. The parasympathetics are the brakes. When the kids are kind of in that first year, they're all amygdala, so they're all emoting, and they're just reacting to everything. And we all have seen like the 15-month-old who's crying over a paper towel being dropped or something like that. And they're not really rational yet. They can't really put the brakes on as easily. And the parent role is that idea of self-regulation and ignoring what you don't want to see, and then supporting what you do, helping the child really understand the norms about being able to handle themselves. And that gets better, obviously, as they get older, when that prefrontal cortex starts kicking in around 6 or 7. And then it's able to keep the amygdala in check. It's able to put the brakes on, so to speak, and kick that parasympathetic pathway in. What happens with kids that have had chronic kind of like deprivation from these reward responses and like these consequences that are happening is that they can look very disorganized, and they can um, have a lot of like negative attention seeking behaviors and negative or positive interactions with adults, because they're not quite sure how to interact with adults, or even their caregivers, or trust what's happening. Go ahead. So, I thinking about this in terms of children, but I'm actually thinking like toddler, like the 1 to 2, or even 0 to 1. Sleep disturbances, regression, behavior changes can happen, hypervigilance, and these are really related to these stress responses. And I'm talking about trauma exposures in childhood, because they do increase the health risk factors in adulthood, and it's a dose response. And we're gonna next slide. So I don't know how familiar you are with these. I think the American Academy of Pediatrics has definitely picked up on this a lot faster than my psychiatric colleagues, but the concept of adverse childhood experiences, I think it's often underplayed how a primary caregiver's mental health is considered an adverse childhood experience. And even divorce or separation, traumatic separations when someone's incarcerated, these are all incredibly important events that are happening, and not just like one time. But mental health problems and substance misuse is a chronic ongoing concern a lot for families, especially when um, the treatment isn't fitting the what the person needs essentially. And so, thinking about this, like how important it is, if you're trying to focus on child health outcomes as a pediatrician, being able to offer that, like being able to kind of think, wow, mom needs to be okay in order for this kid to be okay, essentially. So go forward, please. So what is the role of the primary care provider? So I 100% don't expect people to be writing prescriptions for Prozac for every mom who's coming through. I know the family practice providers out there are much more comfortable treating the whole family, but again, it's a legal licensing issue, and it's a problem when there's no chart. But I think it's important, like when you do assess or identify a problem, um, whether it's with the screening tool or not, you know, addressing it and offering information about it, saying, what is the biggest barrier for you? What is the biggest problem for you? How do you, what do you want to see get better? Is, a really great strategy for motivating, or at least helping someone connect and kind of get into that contemplative stage of, seeking treatment or wanting to focus on that for recovery. And really validating the struggle is incredibly important. Like I can't, usually when I talk to parents, I ask, or the moms on that first month visit, I'll say, who's helping you? And if they, depending on the reaction, is like gives you a lot of good information. And the fewer natural supports they have, the um, you know st- mm, the amount of competing interests, they're probably going to prioritize their own health less. So that would be a great opportunity to, validate that what they're going through is incredibly hard. And then that's really a normal thing that people go through, and help them, figure out what priorities are going to be important to them. Like, how will you know when you need to um, look into it further about having depression and getting some help for it? Like, what would be helpful for you? And kind of just keeping that conversation going is really the critical role of the primary care provider, and passing out the information, or just sharing the information about depression too. Um, and that relationship that you have with mom is powerful. And especially if you're able to kind of keep sprinkling it, just bringing it up whenever it is appropriate and throughout time, it just kind of helps emphasize like how important this is for the child development. That's why you're concerned about it, is that it is going to impact her ability to parent in the way that she wants to parent. Okay. So a few studies have come through motivating our mothers where they offered a screening and offer. So they screened with like a standardized tool, offered education, and I'm going to stress offer education. I think if you're just throwing education at somebody or just telling them all the problems or what it is, it's really hard for people to hear and to digest, especially if they're not in that space or ready for it. So really offering, can I give you some information about how depression can affect your baby's health would be a very appropriate way to start that. And permission to call and follow up. So really it's this continued connection is what has been shown to have the most um, benefit with connecting moms to resources. So the part of it is like the education piece, like here's what we need to do, but it's not just up to the primary care doc. It's like it's more of a system issue with the nurses or whoever support staff you have, like having that follow-up phone call. Were you able to connect with the service? Like, tell me more about it. What's happening? What are the obstacles? Helping moms problem solve, because problem solving is extremely hard when you're depressed because you are disengaged and it's harder to care. It's harder to concentrate and solve um, just one more thing to stress. So the pediatrician's primary care medical home could be very helpful. Also engaging or connecting them with community partners. I know that the Head Start is a nationwide program, an early Head Start. They actually have infant and early childhood mental health consultants that can help kind of pick up on different behaviors and interactions they're seeing and then help the parent, the mom, um, kind of get into connected with treatment or kind of help her work through what's happening as well. And the biggest predictor of mom's well-being is how well she can um, attend or like what her intuition is about the baby. Like if anyone can find out why my baby's crying, it's me. And if they're strongly agreeing with that, like that's a very positive predictive factor. And if they really are struggling with that, like, I don't know what's going on, and they feel helpless, then I would have more of a concern that there's something in the mental health or something happening that is getting in the way of her feeling effective as a parent. All right, so from the pediatrician perspective, we can have, well, I'm going to talk about resources, but I also wanted to just think outside the box a little bit where there are some really specific strategies that are evidence-based for kids and, infant parent psychotherapy. It sounds crazy to be doing psychotherapy with an infant, but it's really about that mom baby connection or the caregiver baby connection. Um, and it talks about like, what their experiences were as an infant, as a baby and child rearing, being child reared, and how that's going to affect their perspective and what they want out of their own skills. It's a really cool, a little bit deeper therapy. The other one is child parent psychotherapy, which I'm a huge fan of, especially with helping regulate emotions, regulating reactions, kind of helping translate the baby's responsiveness and the mom's responsiveness, and kind of really making it this combination interaction, and not just like the bad things that happen in childhood, but also the good things that happen in childhood that you want to highlight. There's some other awesome community-wide or practice-wide um, programs called positive parenting that use positive parenting strategies like Triple P or Healthy Steps or Chicago Parenting Program. These are all evidence-based interventions that are Healthy Steps. I know is particularly trauma-informed approaches where the whole staff can be trained to help identify early signs of developmental concerns. Okay. And I had to admit, I struggled a little bit trying to figure out what specific mental health resources. So, once you identify the issue and you have offer some education about how it can affect child health and parenting, really it's the offering the resources or kind of, sharing that collaborative connection with like who can help her. And the NAMI is this National Alliance for Mental Illness. It's a enormous worldwide organization, but every county even has their own NAMI, and that's a great place to get resources. So I offer this as like from their, the site at the bottom about their, national resource directory, but you can actually dial into, um, you know, specific things about it. There's also, um, actually, I'm curious to hear from you guys. What are the resources out there? But there's a Psychology Today is a great place to get really dialed in with, like, you can filter it by insurance, by nationality, or um, racial preference, or like language preference, age, gender, whatever the issues are. You can search pretty much anywhere in the country. And there's the the AAP also has a resource or a couple of links that historically have worked. I couldn't get it to work this time, which is why I didn't include it, but I'll try to find the updated link for resources for moms to be treated for depression. And I think that's it. So basically, maternal depression, yes, it's kind of part of how we take care of kids, and an incredibly important part in that first 2 years of life, to just kind of have some positive steps moving forward and reducing how many barriers children have to becoming healthy. Thank you for listening.
Thank you, Dr.
Mhm.
Harris. We do have one question so far from the chat box. If anyone has other questions, please feel free to send them in. But the first question is there any correlation between breastfeeding and the presence or absence of maternal depression?
Mm-hmm. Actually, there is. So the connection, and it could go different ways, but I'm assuming they mean the rate of breastfeeding in a mom who's depressed is much less. They're more likely to give up breastfeeding. They're more likely to not breastfeed as long and have a shorter course if they try. And it's it is affected by maternal depression versus parents or moms that don't have depression. Actually, it's interesting. The Brooke Shields book talks about that, how breastfeeding was the literally only thing she could do. She couldn't even hold the baby. They had to hold the baby up to her chest to breastfeed. But when they took that away, it just completely crushed her, and that was her connection. But that was even hard for her to do, which is impressive. I don't have the specific stats on it, but I can get it for you.
Thank you. Yeah, I think that's a great question, a great correlation we'll probably look at even further during the project. Um, I just put in the chat box any other questions. This is a great time. We have a moment here if you would like to send a question, or if you, oh, we do have another one. Generational ACEs are very significant in
Mhm.
child rearing. Do we have any resources regarding generational ACEs?
Yeah, that's like a wonderful topic and question. And the American Academy of Pediatrics did have a workshop on childhood trauma and the epigenetics that happen, and they had a ton of resources. The one that I'm more familiar with right now is through the Center for Youth and Wellness, and that's Dr. Nadine Burke Harris. I don't know if whoever asked the question is familiar with that pediatrician, but she's out of San Francisco. And yeah, it's amazing. The website is incredibly helpful with tons of resources about how to explain it, graphs, how to teach it to your staff, how to like think about trauma-informed care. And there's also the National Child Traumatic Stress Network, NCTSN, that has tons of resources for families about treatment and different options there are out there.
Perfect. Another question related to the graphic with brain levels, how that would be helpful as an education tool to use with clients. Is it available for us to use? I can say that we will be making the presentation available. I'm not sure if any of the pieces are copyright or anything, but if possible,
Um,
we can share.
yeah, I'll take a look, and I think I actually made that slide a long time ago. I don't remember the text I wrote, but the image of the brain. Actually, there's a great one with child brain from oh, I think it's like the Macmillan. If we can, well, I don't know the copyright with it, like how it works, but there's a wonderful, colorful brain, and it has like what to do at each stage of development. It's fantastic, that I really like, comprehensive.
Great. I'm sure we can find some level of kind of different resource to replicate or share that information that we can send to everyone. And then another question, should the ACEs screening be given to a pregnant mother via the phone? I realize telehealth and phone interviews, that's a whole other topic, but any
Yeah,
thoughts?
I think just briefly, the ACEs can be very triggering as well. So it's embarrassing and triggering to verbally respond. I think it's much better to have it written response. And some of the newer ACE screens have looked at just tallying the responses at the bottom versus checking which one you say yes to. They're pretty intrusive questions. So I think over the phone would be concerning to do that with a mom if you don't have the right crisis interventions in place. And rates of depression with different races. Yes. Oh, I took that slide out. Shoot. I think it's very under-recognized in African American women, and there's this perception of being strong, and it's especially anxiety and depression are often overlooked in that particular ethnographic. But I imagine it is different and culturally different too, with how depression is presented, or the symptoms that are from depression versus culturally normal experiences. I'm thinking specifically about Mexican and different type of local cultures around here. This
Perfect.
is an interesting group. I like you guys.
Yes. Thanks everyone for the great questions. Thanks, Dr. Harris, for those answers. We will have another Q&A time at the end of our next presentation, and if time allows, at the end of the entire day, we'll continue having open chat. At this point, without seeing any other questions, we will go ahead and Dr. Macklin, I'll turn it back to you to move us forward.
Yes, thank you. Thank you, Dr. Harris. That was fabulous and a lot of really good information. Let's turn now to Dr. Kartik Venkatesh. I'm so sorry. Dr. Venkatesh is a high-risk OBGYN and perinatal epidemiologist at Ohio State Wexner Medical Center. He is passionate about providing cutting-edge, evidence-based medical care to mothers with high-risk pregnancies. He is currently directing a growing program with an OBGYN for perinatal epidemiology, which includes building public health research and programs to serve mothers and neonates affected by high-risk pregnancies. He has authored nearly 100 scientific manuscripts and has been funded by the National Institute of Health, or NIH. So Dr. Venkatesh, thank you for your time and all the information you're going to be giving us today. Take it away.
He's muted.
Still muted.
How about that? Can you hear me now?
Yeah.
Great.
Perfect.
Thank you, Dr. Harris. Thank you, Dr. Macklin. And in the next about 15, 20 minutes, we will continue developing on some of those themes surrounding postpartum depression. And now taking a little more of a deep dive and focus into the maternal management, as well as screening moms for depression. So to put it out there, for most providers, the idea of screening moms in the postpartum period is hopefully not new. Over the past 10 to 15 years, that landscape has really changed. It's now been almost a decade, really, since the American Academy of Pediatrics, in conjunction with the American College of Obstetrics and Gynecology, came out supporting the need for routine universal screening of all moms at least once in that postpartum period for depression. That has also been in the setting of individual states having mandates surrounding mandated universal screening in the postpartum period, primarily in the Northeast. That hasn't been the case necessarily in Ohio, but suffice to say that the movement towards professional screening by our professional organizations has been in consort with legislation that's been passed surrounding mandated universal screening for postpartum depression. So that's some food for thought. That being said, the rates of postpartum screening in pediatric practices, as well as by primary care providers and OBGYNs, has progressively gone up over the past 10 years, but there's still concern that we are missing moms. Recent CDC PRAMS data suggests that anywhere from 1 in 10 to 1 in 8 women who should be screened aren't getting screened. And disturbingly, there are variations in screening regionally across the United States as well. Next slide. So what are some of the maternal risk factors for postpartum depression? When screening a mom and thinking about her risk for depressive symptomatology, some of the most common risk factors are things like teen pregnancy, minority race, a prior history of trauma and intimate partner violence, a mom's own history of psychiatric illness, infant death, stillbirth, as well as the growing recognition and is the notion that a mom who has had a baby in the NICU or a baby with complications in that pediatric period, no doubt is also at very high risk of mental health issues. And that's also a growing area of research. And then finally, the role of substance use in pregnancy, tobacco use in pregnancy, and how that may also contribute to maternal postpartum health. Next slide. So then what are some of the barriers to identifying and treating postpartum depression? In the past, it's often been providers and patients lack adequate information about postpartum depressive screening. Hopefully that has changed in the past decade or so, given the mandates surrounding screening in the postpartum period, given a greater emphasis on this, given more availability of web-based resources, individuals in popular culture speaking about the role of postpartum depression. So hopefully that conversation has continued and evolved to change in a positive manner. An additional challenge has been that some of the symptoms that may be associated with depression, such as fatigue and insomnia, may also be normal in the postpartum period. So it can be somewhat challenging at times to disentangle the two. Often, mothers may be in denial of their symptoms and may feel stigmatized to report those symptoms to a provider. Providers themselves may minimize these symptoms or may consider them to be, normal in the postpartum period rather than understanding that this could be pathology. And then, tied to this is a fear on the mom's part of being labeled as mentally ill, and what does that mean for her and for her own sense of being a mom. And then probably the last one that's bolded here is perhaps the challenge that many of you as providers will face with the implicit program, which is that lack of coordinated care as well as methods of referral, which comes back to what we'll talk about in the next few slides, which is that, okay, I've screened a mom, I did the Edinburgh Depression Scale, she scores 11, she is interested in being hooked up with greater services, but what do I do as a pediatric provider? So how do I connect a mom for further evaluation and then potentially management for depression if I've screened a mom? So I think that is perhaps one of the biggest barriers that we continue to face, and particularly in settings where we see moms who are potentially on Medicaid during their pregnancy, and then the mom loses her pregnancy Medicaid in the postpartum period, then gets screened positive for depression by a pediatric provider. And then naturally, the next question is, then what? How do I get the mom the needed services that she needs? So that is a real dilemma. Next slide. Finally, provider level barriers to screening. And one question that remains to be fully answered is that to what extent does screening and intervention ultimately lead to improved patient outcomes? So that is an area of active investigation. And then finally, I think a barrier that many providers may face, particularly in the pediatric setting, is, to what extent is that my professional role and my relationship with the patient, particularly if I'm treating the child, to what extent do I screen the mom and refer the mom to needed services? And then finally, the question that we've addressed in the prior slide, which is, okay, I've identified a mom, what do I do? Where do I go for referral? And as Dr. Harris pointed out, I think this is an area where web-based resources and local postpartum support groups can be a great way for moms on their own to be able to seek resources in consort with perhaps also, seeking referrals through their primary care provider, for example. Next slide. So then the question becomes how to screen moms, and what are we going to be doing in our individual clinical practices to screen moms when we see their children. So the idea of an effective screening tool is that that it has multiple versions of the same scale. It's brief, which is important for those who are working in a busy clinical practice. It needs to be generalizable across SES status, multiple different languages, accounts for cultural differences. It needs to be utilized in multiple different clinical settings. Sensitivity is very important. We can compromise specificity, but for an initial screening tool, we want to make sure we're not missing moms. And it obviously has to have construct validity for our disease of interest. Next slide. So keeping in mind those principles of effective screening, there are multiple different screening tools that have been used for postpartum depression screening. If you look at AAP guidelines or ACOG guidelines or go to USPSTF, these are some of the screens you'll see. Probably the most commonly used screen in practice over the past decade or two has become the Edinburgh Postnatal Depression Scale, EPDS. It's been validated across populations, across ages, across different countries. It's been validated in pregnancy as well as postpartum period. It's quick, it's 10 questions. It only takes a few minutes to complete. Sensitivity greater than 80%, often in the low 90s, and fairly specific. It also has individual subscales that can be implemented of 2 to 3 questions if you can't do all 10. But it is generally easy to deliver in a clinical care setting. Moms can complete it themselves as a paper questionnaire, as a web-based questionnaire, or on an iPad, or it can be asked by a provider as part of clinical care. So, EPDS is probably what is most commonly used in our clinical practices. And if not the EPDS, the PHQ is most commonly used in this setting. Next slide. So so this is the full EPDS that you can see right in front of you, and it asks for recall over the past 7 days. It's easy to do as a brief multiple choice, 1-page survey with your patients. Some research has been done. If you can't do the full 10 questions, are there shorter versions of the EPDS that have reasonable sensitivity and specificity, and that's been shown. So that's also an option. But I would say in general, implementation of the full EPDS, all 10 questions, is generally not a major problem to implement as part of clinical care. Next slide. So then if you used a screening, then what next? So in the most rigorously done screening studies, the cutoff that's often used is 12 or 13. But often in clinical practice, we want to maximize sensitivity to make sure we're not missing moms. So many providers often use a cutoff of 10, which is reasonable. So, a cutoff greater than 10 to screen moms as positive for referral is what's most often used, but the research often uses a slightly higher cutoff. Again, it's online and it's short. And an advantage of the EPDS is that it distinguishes psychological symptoms from some normal somatic pregnancy and postpartum symptoms. It can be used in primary care. It doesn't take much time. And it can be done by providers with limited mental health training, so that's important. Next slide. So current screening. Some of the barriers that we continue to face are that despite the push to screen moms and despite growing public awareness, repeated studies show that we are still only recognizing, unfortunately, fewer than half the moms who are ultimately diagnosed with postpartum depression through postpartum screening. So there's still much work to be done in this area. And I think one aspect of this that's hopefully been highlighted today is that what we really need is a multimodal approach where, you know, screening is not the responsibility of necessarily just the OBGYN or the pediatrician or the primary care provider, but it is happening at multiple time points and in multiple clinical venues and by multiple providers, because that's really how we are going to be able to identify these moms better. Again, you know, a major barrier has been that, you know, with screening is that is not only are we missing moms and they're not being screened, but even if they are potentially identified, the EPDS is not scored appropriately. So that's, again, potentially a major barrier. But hopefully, you know, some ways that can get better is that some practices are able to have the EPDS completed either via iPhone or web-based platform or an iPad. So that can also improve the accuracy of screening. Some studies have suggested that, you know, the EPDS can effectively be done by the nurse, essentially as a vital sign at the time of a pediatric visit. So that's another approach to take towards screening. And then electronic reminders can also be used for screening as well. And that's perhaps another way that screening rates could be improved. And then finally, I think having a universal protocol is so important in this area, because often, you know, individual providers may remain undecided as to how to screen in terms of, you know, what instruments should they use, or if they're not using a screening tool, what questions should they ask? So I think one of the best ways to improve screening practices is to have a universal policy that all providers in an individual practice are using, and to make sure that everybody is using the same screening tool and that it's being delivered in a similar manner across the board. So with that, I think there have been a few questions that have popped up over the past few minutes, and I'd be glad to answer any questions that people have.
Thank you. Thank you so much. So I will just start with the questions in the chat box. If anyone has others, please feel free to send them in. The first that came in was, what's the correlation between tobacco use in pregnancy and postpartum depression?
Yeah, so that's a great question. So, you know, substance use in general, and more specifically prenatal tobacco use, has been shown to be associated with a higher risk of postpartum depressive symptoms, as well as lower rates of breastfeeding, as well as a higher rate of SIDS. And to what extent is that due to an underlying causal or biological etiology mediated by inflammation, oxidative stress, changes in the HPA axis? Yes, but there's also other social and confounding factors that play into that relationship. So, you know, disentangling the contribution of prenatal tobacco smoke aside from those other factors is very challenging. But suffice it to say that it's probably acting both directly as a causal risk factor, but also is also you know, prenatal tobacco exposure is occurring with a whole host of other exposures that increase the risk of postpartum depression.
Great, thank you. Good information. So another question, And I'll paraphrase a little bit, but if a mom is uncomfortable with being screened because of fear this could be used against them in court, perhaps for a custody case, not necessarily worried about stigma, but more about that particular use, is there anything that can be done to assure them of the need for their screening and that it won't be used against them?
Right. I think that's an important question. And I think there has been a growing recognition about concerns surrounding, as healthcare providers, our role in screening moms for mental health issues, substance use issues in the setting of pregnancy, and what does that mean in terms of child custody issues and the legal system. And perhaps that's been I think the place that most recently highlighted is in the setting of, in pregnancy in the postpartum period, doing urine drug screens on moms, and how sometimes, those universal drug screens that may be done are how that may have adverse impacts on families and on moms that sometimes providers may not even recognize when screening moms. So I think that this is an area of concern that we should all be concerned about, and we should all be thinking about. That being said, I think, screening for depression as a mental health condition, obviously, is very different than the legal implications for, let's say, of screening for illicit substance use, for example. Both the legal implications of both of those are very different. So I think we can be in a position of reassuring moms that screening for, let's say, substance use potentially has very different legal implications than screening for maternal depression, which is essentially no different than screening a mom, let's say, for hypertension or diabetes, really.
Perfect. That makes great sense. And then another question related to screening. Does the EPDS ask different questions than the prenatal Edinburgh? Some people are using one tool for pre and postnatal, but is that a best practice?
Yeah, so the EPDS that you're now commonly using in the postpartum period, that has been validated for use in pregnancy as well. So you can use the same EPDS across the board. And, the best practices that are now being recommended by the American College of OBGYNs is basically, you can use the same EPDS that you're using at the postpartum time period to use it throughout pregnancy. And ideally to even be screening women once per trimester if possible.
Okay, perfect. And then I see one last question in the chat box. What is the best approach to use with OBs or other physicians or other providers to get buy-in for screening?
Yeah, I think getting buy-in for screening comes back to, being able to do it efficiently, which comes back to using the same screening tool that's been validated. So that, I think, is now readily available. Doing it efficiently has now become easier because you can obviously do it on an iPhone. You can do it via a web-based platform. If you have a protocol in place in your practice, the patient can themselves fill out the EPDS, and then it's just a matter of quickly scoring it. So I think getting buy-in, a lot of that can be done effectively by having a simple, universal protocol in place. I think that's so important to getting buy-in. And then thinking about, and I think the last part of that is that what I think is the elephant in the room, which continues to be the problem of linking moms that you screen positive to mental health services or to a provider who can then take that screening result and then decide, do they meet diagnostic criteria? And then, what is the most appropriate approach? Is it being on an SSRI? Is it getting CBT or behavioral therapy, or both of those things? I think having that as part of your protocol. So, not only your screening protocol, but in terms of then, what are you going to do for moms in terms of how are you going to link them to those services that we've described over the last 45 minutes that Dr. Harris also described. having that as part of your protocol, I think is so important to getting buy-in.
Yeah, the AAP put out a practice protocol or clinical practice policy, I think, about how often and what to use for screening and what to do to respond. It's very similar to what we do in pediatrics for adolescent depression already with the GLAD PC. Of that continued follow-up piece and the active monitoring piece. So I think it's a really cool way to think about the role of the pediatrician being one of those key players of connecting the depression to parenting and to the child development is something that we can do, but nobody else could do, essentially. And then the OB has the role of, actually, I'm not an OB, so I'm going to say but then, and like everybody, even all of the, the care coordinators, like everybody has a role to be value added to that mom's health and then overall health outcome of the child. It's neat.
Perfect. Well, thank you, both of our presenters today for your information, for sharing this with such a big audience. I think the questions also have really helped with thinking about some of the situations. At this point, so that we wrap up close to time, I'm going to recommend if you have other questions, feel free to send them in via chat or send them to me via email after the presentation, and we'll compile those and try to get some answers. But at this point, we can probably go ahead and I will see if Dr. Macklin is ready to bring us home.
Go ahead. All right, we're going to spend just a couple minutes talking kind of the end about bringing this all together. And that is through the Healthy Mom, Healthy Family Quality Improvement Program, again, otherwise known as implicit. You might hear that term being thrown around. Implicit stands for Interventions to Minimize Preterm and Low Birth Weight Infants Through Continuous Improvement Techniques. It is an interconception care project where we focus not only on pediatric health, but also on maternal health during pediatric well child visits in the first couple of years of life. So this QI initiative empowers providers to recognize and address maternal health issues, such as mental health issues that we've discussed today during these pediatric well child visits. If you would like some more information on this initiative to be involved, or even, again, just to get some questions answered and get some information, you can contact Haley with the information here, either email or phone number. As far as the project, we will be accepting 13 to 15 practices during, in the project starting next year. They will receive access to multiple resources. And so a little bit more about the project. There will be a very simple screening tool to use. There will not be any chart review data collection. Practices can receive up to $1,000 in resources for patients to be used for things like multivitamins, board books, technology assistance, and printed materials. Providers will learn how to implement the 5 A's to promote behavior change for lifelong health. There will be networking opportunities with providers interested in infant mortality or interconception care. Providers will also receive personalized QI coaching and Ohio AAP resources. And participants in the year-long collaborative can learn up to 50 points of MOC Part 4 credit in 2021. So again, we thank you for your time in this presentation today. Here are a few other updates and resources, the family resource page, the COVID-19 resource page, and then some further education online tools through the Ohio AAP. So again, thank you for your time. Again, contact Haley with any questions, concerns, and we greatly appreciate your questions and attention to this really important topic with maternal and child health. Thank you.
Thank you for those who showed their faces. I like to see who we're talking to. Thank you.
Thanks, everyone. Thank you to our presenters and to our attendees. We will send a follow-up with information related to claiming CME and resources, and appreciate your participation today. Hopefully I will see you in another one of our trainings soon. Everyone have a good day.
Thanks, Al. Have a fabulous day. Bye-bye.